very own, a future ophthalmologist, somebody who's going to make a real dent in our field, Chad Lewis, who's our MS4 applying in ophthalmology right now, and many of you have heard him speak before. He has a case presentation, and then Nick, I'll just let you go straight into your presentation. Nick's going to be presenting on the update of intravitreal injections. So you guys go ahead and take it away.
Thanks, Dr. Selcom. I'm very happy to be here. So today I'll be presenting iris prosthesis following traumatic aniridia, a case report and review, and I have no disclosures. So in February 2009, a 37-year-old male was hit in the eye with a stick and suffered an open globe injury while he was working on a snowmobile trail. When he presented, his visual acuity on the right was light perception only, and he had significant hyphema with an infratemporal limbus to limbus corneal laceration in pretty much that whole quadrant of the eye, with extrusion of most of his lens. Luckily, the central visual axis was spared and his natural crystalline lens was clear and intact, but some zonules were traumatically detached in that quadrant as well. We don't have any photos from the original trauma, but this is what he looked like on postoperative day 1. So the cornea was sutured with 10-0 suture. You can see some of the hyphema that was still residual hyphema here, and pretty significant laceration. On postoperative day 30, you can appreciate the aniridia a bit more with the red reflex here. So it was pretty much a complete removal of his iris. And hopefully you can see the zonules are still intact here in this picture, and the zonules are intact here in this picture, even though the capsular bag is significantly subluxated because the zonules have been traumatically detached throughout this whole region here. And that'll come into play a little bit later. So just to recap aniridia, it's the complete or partial absence of iris. It can be congenital through a PAX6 mutation, or acquired either through trauma, or if someone has a melanoma of the iris and it's extracted. So any type of missing iris. This occurs naturally in 1 out of 50,000 to 100,000 newborns in the US. And it's not only a cosmetic condition. It can cause a reduction in visual acuity. The patients experience a lot of glare, photophobia, and it can even cause glaucoma. And a majority of these patients will eventually develop a cataract. So for over the next 8 months, his cornea healed well. His visual acuity returned in the right eye to 20/25 with 1.5 diopters of cylinder correction. But even though he was using an iris contact lens, he was still experiencing blurry vision, glare, and photophobia. And he was referred back to DH from his optometrist for the early signs of a cataract. And he was evaluated by Dr. Miller, and he recommended cataract removal with iris prosthesis. At that time, the HumanOptics artificial iris that I'll be discussing today was only in its very earliest phases of beginning to look into starting a clinical trial, and it didn't receive approval for humanitarian use until the following year in 2010. Excuse me. So Dr. Miller referred the patient to Dr. Roberto Pineda at Mass Eye and Ear to potentially be included in the HumanOptics CustomFlex artificial iris trial, but he actually ended up not receiving the implant until 2015 when he went to Cincinnati Eye Institute and received it from Dr. Michael Snyder there. Just to talk a little bit about the clinical trial, 389 patients were in this non-randomized trial, and 70% of them reported significant decreases in light sensitivity and glare and increased quality of life, and 94% of them were satisfied or very satisfied with the appearance of their iris after receiving it. And here are just a few examples of what that implant looks like. So this is the first standalone prosthetic iris available in the US. It was FDA approved in 2018. It's indicated for treatment of symptomatic aniridia in any patient above the age of 30. And it's a custom-made implant. It's medical grade silicone, similar to what a silicone IOL is made from, and it requires the provider to take a specific set of photos of the iris in the unaffected eye, and that's sent to HumanOptics AG, which is a German corporation, and they have skilled technicians who will, excuse me, paint the iris by hand to make it match the photos. It takes about 4 to 8 weeks for this process, and then it'll be sent back. And it can be combined with most IOLs. It's designed for posterior chamber placement. The natural crystalline lens needs to be removed, so this is only for aphakic or pseudophakic eyes. There are multiple configurations. It can be placed in the capsular bag, as you can see here. This is a in the capsular bag. This one is actually planted in the sulcus behind. This is the natural iris here, and then this is where the artificial iris is behind that. It can be used with capsular tension rings, and there is a fiber and fiber-free variant. So the only difference between those is the fiber variant is reinforced with fibers so that it can withstand the tension of suture. So if the lens needs to be sutured in place, you would use the fiber variant. I'd like to just take the next 3 minutes to show everyone a video of this. I think it'll be really helpful for you to see it go in place, and it's pretty interesting. So you'll see right at the beginning of this video, the person who's introducing it is Michael Snyder, who is the surgeon who did the implant for our patient. And please let me know if there's any audio issues if you're not able to hear the video.
An additional option we have for iris prostheses is the custom flexible artificial iris from HumanOptics. This device is handmade for each patient, matched to a photo taken from an uninjured or unaffected eye. Dr. Sam Maskett from Los Angeles, California, will show us how this custom flexible device can be implanted through a small incision.
A 70-year-old woman sustained a narrow angle glaucoma attack, ultimately requiring 2 glaucoma surgeries, and she was left with a fixed dilated pupil with a very thin iris, a nearly mature cataract, significant cosmetic defect, and glare. At surgery, a femtosecond laser was used to create a 6-millimeter anterior capsulotomy, which is being teased toward the center to assure no tags or adhesions. Once the capsulotomy is removed, phacoemulsification is carried out, and the femtosecond laser divided the nucleus into sextants, which are then chopped and removed by phacoemulsification without significant difficulty. Periodically, additional dispersive visco agent is added to the chamber in order to protect the already compromised endothelium. Once the capsule bag has been emptied of its contents, the lens epithelial cells are removed with a single sweep, and a capsule tension ring is placed in the capsule bag, followed by a single piece of acrylic lens. Under air, trypan glue is then used to stain the anterior capsule to aid visibility during iris implantation. A fiber-free version of the device is then inspected and trephinated to 9.5 millimeters to match just below the diameter of the lens capsule bag. Careful placement of the trephine allows a perfect cut, and the central aspect is then folded in a trifold manner and then implanted into a silver series cartridge under viscoelastic material. Under protective OVD, the iris is injected into the anterior chamber. It is helpful to place the edge under the capsule, but if not possible, under copious visco agent, the iris is then unfolded and then teased under the edge of the anterior capsulotomy. And here the trypan blue makes visualization easy. Once the iris has been placed under the capsule edge for 360 degrees, the OVD is removed. And in this case, because of the filtration of blebs, a tenonylon suture is placed. Now, while the central iris appears a bit light, it matches perfectly with the fellow second eye. And here, 1 year later, we see the excellent aesthetic and function result with the patient being returned 2020, free from glare and looking rather normal.
Thank you, Dr. Mieskit.
Okay, so that's a pretty good example of what the surgery is like. You can see there's very good cosmetic results most of the time, although the surgeons who are very experienced with using this say that sometimes it is hard to center the pupil in the cornea if there is an open globe injury, but most of the time there are very good cosmetic results. So in moving forward 5 years, in June 2020, now our patient's age 48, he experienced 1 to 2 weeks of subtle vision changes prior to a new onset of an amber colored area of his visual field. And overnight, this developed into a field cut from 12 o'clock to 7 o'clock. So he saw his optometrist, Dr. Shippey, in Lancaster, New Hampshire, and was referred to Dr. Batra, where he was found to have only hand motion, visual acuity in the right eye, and macula off retinal detachment. So he was urgently taken to the OR that day for a scleral buckle and pars plana vitrectomy with endolaser. One thing to keep in mind that can present more of a challenge for vitreoretinal surgery with one of these irises is that it has a fixed pupil size of 3.35 millimeters. Here's a B scan and OCT of his eye on June 17th, which shows a significant retinal detachment here. And this is where we got the first look of his artificial iris. So you can see it looks good. There's a Chioni capsular tension ring. I'll go to a zoomed in look at this so you can hopefully see this a little bit better. But because of the amount of zonular detachment that he had in the infratemporal quadrant, the capsular tension ring helped move the capsular bag centered and provided extra support. So this ring, it almost complete 360 support to the capsular bag. You can see the loop of one of the arms here. There's another arm that goes around this side. And the cool thing about this type of capsular ring is it has an arm that comes up out of the capsular bag and can be sutured into the sclera as an anchor. So a CB8 Gore-Tex suture was placed here. Here's another look at that Chioni capsular tension ring, designed by Robert Chioni, who's another surgeon at Cincinnati Eye Institute and another surgeon who is involved in the clinical trial of the artificial iris. It's indicated for patients with extreme zonular weakness or if they're missing zonules larger than 4 clock hours. And you can see here that offset that allows this to be in the capsular bag, but this to come out of it. So the retinal detachment repair was a success. You can see here at 1 month out on the right, his retina is back in anatomical position. He was seen again at 6 weeks post-op and still had good results and was followed up by his optometrist. So key takeaways for clinicians are this is indicated for symptomatic aniridia, either congenital or acquired in patients above age 3. It should only be implanted during cataract surgery or in eyes that are aphakic or pseudophakic. It is not appropriate for cosmetic eye color change, and it is not an MRI safe device. And just to look at a few of the contraindications for the artificial iris, that concludes my presentation. So I'd be happy to take any questions. Thank you.
Chad, this is Dr. Miller.
Hey, Dr. Miller.
Tremendous presentation. I think it's an astonishing that patient is the recipient of 3 incredibly successful surgeries for 3 different situations. His initial open globe repair with a really good corneal result with not much astigmatism. And then the center of your presentation, the cataract and then the iris prosthesis, which is beautiful, and then an incredible retina repair through a tiny pupil. I mean, he's really a beneficiary of incredible work. Nicely presented, and that iris is very, very enticing to think about trying to use one of those. But anyways, just some time. Nice job.
Thank you. And I should have mentioned his vision did return in that eye to 2025. So he had not only good cosmetic results, but he received a lot of functionality from the surgeries as well. Here are my references.
Hey, Chad, this is Dimos Mantopoulos.
Hey, good morning.
Good morning. That was a great presentation. Just a quick question about whether the insurance would cover this implant.
So if the patient does have symptomatic aniridia, I've read that most insurances and Medicare will cover the surgery.
And do you know whether one of the doctors in Boston now does this procedure?
Based on their website, there is currently no one except for a surgeon in Albany, New York, and one in Warwick, Rhode Island. So no one in Boston, no one in Northern New England currently. If you go to the HumanOptics AG website, they do offer an online training for surgeons to be able to order the HumanOptics implant. So that would definitely be something to consider if we wanted to be able to expand that service to Northern New England. We would pretty much be the only game in town.
That's interesting. Thanks.
I was surprised that Boston wouldn't have a few surgeons, especially given that Dr. Roberto Pineda was involved in the original trials. So it is possible that their website is just not catching everyone who's able to use it. But based on what I was able to find from their surgeon locator, there's no one in this area.
Do you know why Dr. Pineda stopped doing this procedure?
No, I do not. And I'm not sure if he did stop doing the procedure.
Okay.
I was trying to piece together the timeline a little bit, but between when Dr. Miller referred him in February 2010 to Dr. Pineda, at some point the patient must not have been included in the trial because it was another 5 years and he had to go to Cincinnati Eye Institute to receive the implant. So I don't know why Dr. Pineda didn't provide the implant.
Okay. Thank you.
Sure thing.
Hey Chad, thanks a lot. I'm going to transition to my presentation. Why the iris is not compatible with MRI?
No, I'm not sure. I tried to figure that out, but I wasn't able to find it on the HumanOptics website. I just read through their professional information white paper, and it said that it just had a symbol saying MR unsafe. So I don't know if it's the fibers. Maybe the fiber version is MR unsafe and the fiber free would be okay. But that would definitely, I can investigate that a bit.
Yeah, this is Erin. I was just thinking of that as being a significant issue long term. You know, if you're thinking about putting it into a 3-year-old, for them never to be able to have an MRI, and this isn't something that's easily removable,
Right,
could potentially be an issue. But
Can everybody see my screen? This is Nikhil Batra.
yep, looks good.
Okay, sounds good. So we'll get started. I know that people have to get off to their clinic, so I've purposely made this short and sweet. So my topic is a bit drier than Chad's. We're going to answer some frequently asked questions about intravitreal